Hello and welcome. This video has been designed as an experiment to facilitate learning for postgraduate students. Every slide has a question regarding hypothyroidism in pregnancy. After you have read the question, you will get 15 seconds to come up with the answer. After 15 seconds, the answer will be revealed and we will move on to the next slide. We welcome your comments about this learning process and let us know if the 15-second time is too much or too little, or if this kind of video has any value. So let us proceed. Now this is the first question. What is the prevalence of clinical hypothyroidism in pregnant women? The answer is the prevalence of clinical hypothyroidism in pregnant patients is not known at population level. International studies in clinical environment demonstrate the following results. Overt hypothyroidism is estimated to occur in less than 1% of pregnancies, 0.3 to 0.5. However, subclinical hypothyroidism will occur in 2 to 3% of the population. Hyperthyroidism also has a very low prevalence of less than 1%, 0.1 to 1.4%. Now let us move on to the next question. What are the symptoms in overt hypothyroidism in pregnancy? The answer is, for mild hypothyroidism, the symptoms are very mild, making diagnosis difficult. But for more severe hypothyroidism, patients may complain of lethargy, weight increase, constipation, cold intolerance, stiffness of the muscles, muscle cramping, carpal tunnel syndrome, dry hair and skin, slow speech and movement, forgetfulness and difficulty with concentrations. For students, it will be advisable to categorize their symptoms into 3 or 4 categories to help you to remember these symptoms. And it doesn't really matter in which order you tell these symptoms. Okay, let's talk about the physical signs in overt hypothyroidism in pregnancy. The answer is that physical signs may include a large tongue and an expressionless face in severe disease. Eye examination may reveal periorbital puffiness, and examination of the extremities may reveal non-pitting edema and hyporeflexia. Okay. What is the differential diagnosis of hypothyroidism during pregnancy? The answer is different kinds of thyroid diseases such as hypothyroidism, tertiary hypothyroidism or secondary hypothyroidism, subclinical hypothyroidism, thyroiditis, hyperthyroidism, or the other conditions include depression, chronic fatigue syndrome and anemia, fibromyalgia, chronic kidney disease, or menopause. Moving on to the next question. What changes take place in the maternal thyroid gland during pregnancy? The answer is that early in pregnancy, TSH levels can increase due to the effects of human chorionic gonadotropin, but T3, T4 levels will remain normal. Pregnancy-related hormonal changes, especially HCG, can lead to mild thyroid enlargement, but this is physiological. As pregnancy progresses, the TSH levels will come back to normal levels, and the thyroid hormones FT4 and FT3 will remain stable. Now, some of you may have a question about why the thyroid levels go down in patients with hypothyroidism. In hypothyroidism, the levels go down because of the increased circulating volume, decreases the levels of TSH and T3 and T4 in the blood because the thyroid gland is not able to cope with the stress of pregnancy. But in normal patients, the thyroid gland is able to cope with the stress of normal pregnancy and will be able to increase the thyroid levels accordingly. I hope that is clear. What effect does pregnancy have on iodine levels in the mother? The answer is adequate iodine intake is crucial for thyroid hormone synthesis, but during pregnancy, iodine requirements increase due to the needs of the developing fetus. So the fetus does not need iodine directly. It is the mother who needs more iodine to make sure that enough thyroxine is being produced to meet her own needs and to pass through the placenta to the baby in the first trimester. After the first trimester, the fetal thyroid gland starts to synthesize thyroid hormone. And now the fetus also needs iodine to make sure that the thyroid function can continue. If there is insufficient intake, maternal intake, then this can lead to thyroid dysfunction in the mother, but more importantly, it can lead to the developmental issues in the baby. So the next question is, what is the thyroid function of the fetus and how are the fetal iodine requirements met? So the thyroid function of the fetus, the answer to this is, during the first trimester of pregnancy, the fetal thyroid gland is not yet fully functional. So the fetus relies entirely on maternal thyroid hormones for brain growth. Insufficient thyroid hormone in the fetus can lead to brain neural tube defects and also to other organ defects. For example, the heart, the liver, and the fetal liver and the lungs. Proper levels are crucial to ensure healthy organ formation, especially in the first trimester of pregnancy. After the fetal thyroid gland will develop, the fetal iodine requirement will also increase. Next question. What are the complications in pregnant patients with hypothyroidism? Okay, the answer is the following: microcytic anemia, preeclampsia, placental hemorrhage, postpartum hemorrhage, cardiac dysfunction, miscarriage, etc. Next question. What laboratory studies are done in pregnant patients with diagnosed hypothyroidism? I'm going to give you 10 seconds to answer this question. And this is the answer. In overt hypothyroidism, TSH levels are elevated and the FT4 value or the FT4 index will be low. But in subclinical diagnosis of hypothyroidism, the FT4 values are normal, but the TSH levels may be elevated. And the tests for anti-thyroid peroxidase antibodies and anti-thyroglobulin antibodies should be measured in pregnant women with possible hypothyroidism to determine if Hashimoto thyroiditis is the cause. Next question. Again, I'm going to give you only 10 seconds. What are the lab tests required in pregnant patients with hypothyroidism? The answer is that as hypothyroid can be associated with decreased metabolic activity, some investigations have to be done other than thyroid hormones. The hormones influence bile production and the flow of bile from the liver to the gallbladder and to the intestines. And bile is essential for digesting fats and eliminating waste products. In hypothyroidism, the reduced thyroid hormone level can lead to decreased bile production and flow, potentially causing issues with fat digestion and absorption. And this is the reason why we perform liver function tests in hypothyroidism. Anemia is also observed in as many as 30 to 40% of patients because of decreased erythropoiesis. And there may be a concomitant vitamin B12 or folic acid deficiencies, but leukocyte and platelet counts will remain normal. What are the fetal and neonatal complications in maternal hypothyroidism? 10 seconds for that. And this is the answer. What imaging studies can be done for thyroid function in pregnant patients? The answer is very simple, straightforward, so I'm not going to challenge you with it because ultrasound is the only one, and we do that if we can detect a nodule or to make sure that whether it's a cystic nodule or a solid nodule. And radioactive iodine uptake testing is contraindicated. How will you plan the medical management of a patient with hypothyroidism during pregnancy? The answer is that in women who are already diagnosed, thyroid hormone should be increased by 30%. If they have been first diagnosed, then a full replacement dose of 1.6 to 2 micrograms per kilogram per day should be started if first diagnosed during pregnancy, and the recommended mean intake of iodine during pregnancy and lactation is approximately 250 micrograms per day. What is the prognosis for pregnant patients with hypothyroidism? You're going to get 15 seconds for this response and the time starts now. So the answer is that if the women have euthyroid status, which is either naturally or because of treatment, satisfactory treatment, then the outcomes will also be satisfactory. And similarly, in the postpartum period also, we have to be careful that medical therapy is adjusted to ensure a euthyroid state. And this will ensure a good progress. This is an easy one. How should patients with hypothyroidism be educated during pregnancy? And I'm going to give you 10 seconds. The time starts now. So the answer is that you have to ensure the patient and her family understands It is critical that the thyroid levels are maintained during pregnancy to ensure maternal health as well as to ensure fetal health and lack of complications and congenital abnormalities in the fetus. And this levels can be achieved by the patient taking her medication regularly on a daily basis, as well as on checking to make sure that her lab investigations are done every 4 to 6 weeks. Now we come to the last questions. Should all pregnant patients be screened for hypothyroidism? The answers, I'll give you 15 seconds for this, and the time starts now. Okay, the answer is that the American College of Obs and Gynae do not recommend universal screening for thyroid disease in pregnant women, and screening is recommended for those who are at increased risk because of a past history of some problem in their pregnancy as far as the fetal outcome is concerned, or if they have a personal history or a family history of thyroid disease, type 1 diabetes mellitus, symptoms suggestive, or if they have a palpable thyroid nodule. But there is no room for screening in women who have a mildly enlarged thyroid gland in the first trimester of pregnancy. So with this, we come to the end of our video. If you like this method of preparing for exams, please like, subscribe, comment, and share the video. Also give your comments on the time given for the answer. Is it okay, too much, too little? Please subscribe and press the bell icon for further notification of videos. Thank you and goodbye.